For everyone with an interest in NASH or more broadly fatty liver disease, Surf's Up, Season 4, Episode 14 of Surfing the NASH Tsunami. Our look ahead to the second quarter and an exciting middle year starts now.
This week on Surfing the NASH Tsunami.
We have an awful lot to do in the second quarter.
The only way we are going to save healthcare in any system is to stop getting sick where we can prevent it.
We urgently need a clinical trial showing superiority of screening versus no screening in the general population.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader, Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, and pricing and forecasting guru Roger Green, as they preview some of the major NASH and NAFLD stories of the next 3 months on Surfing the NASH Tsunami.
So this has been an interesting event to schedule. Professor Schattenberg will tell us later about some of his travails getting out of California and back to Germany and what that's done to his schedule. But the net result is, as you know, we usually post on Wednesday night. Well, this is Thursday afternoon, and we expect we'll be posting on Friday morning. But to have Jörn with us is absolutely worth it. There's no doubt about that.
Well, thanks, Roger.
But after everything you've gone through to get home and be here, it's a good thing. And we have Louise, who will not be with us for the next 2 weeks because she'll be off skiing in Western Canada. So we'll get to hear her for the last time in a little while. She'll be back for our anniversary celebration, which I'll talk about later. And Louise, how are you today?
I'm very well, thank you very much.
Now, when do you pack out to Vancouver?
Sunday. And I can't wait, but there's a strike. And I'm sure Jörn's going to tell us a little bit about Germany. We got a security strike. So I'm going to just relax as I go through the security system. Because I'm on holiday.
So you need to get there 8 hours early?
No, they won't allow you to go much before the 3. They're trying to manage it, but they have cancelled a fair few short-haul flights, so probably to Europe. So we apologise for all of our long-haul that are going.
Well, I'm clearly jealous you're going skiing. This is a great time of the year for this, and I'm sure you're going to be enjoying it. I was going to propose that you join us after the slope, but sometimes skiing days are tough.
They are, but clearly I'm not that fit, so yes, they will be tough, and I'm 8 hours behind, so you never know.
Yeah, that more to the point. Western Canada is Pacific time. At any rate, Jörn, why don't you tell us a little bit about how much fun you had going from California to Germany? And then I'm going to ask you to give us a recap on the 2 events in California, and then we'll do icebreaker and go to the main topic of today's, which is taking a look at what's going to be a rather extraordinary second quarter of events that we'll be covering. Your floor, my friend.
Yeah, well, I was going to start with saying what actually brought me to California in the first place, because that was a lot of fun. There was the Chronic Liver Disease Foundation meeting, the Liver Connect and NASH Connect meeting, which was a great event hosted by the CLDF steering committee and a lot of industry involvement. It was a great place just to get there and discuss and, get the latest and hottest on development. So really enjoyed being there. It was held in Huntington Beach, not too far out of Los Angeles, which is a pretty place for anybody who hasn't gone there. It's worth the trip. I had some time off, so I went for a run down the coast, and it was quite enjoyable. The other meeting that was, I think, not intentionally planned on the same weekend, but it's been scheduled for some time by ASLD's, the NASH Cirrhosis Special Topic Conference. Mazen Nureddin was one of the organizers, along with Anna May Deal and Robert Schwabi, a German colleague who's doing basic science and quite some interesting stuff on stellate cells in New York. So that was a meeting heavily focused on only NASH cirrhosis, and I was involved in a session on therapeutic approaches, and we kind of went through the rational and background potential data that was available for a number of MOAs we're discussing here, including something on FGFs, PPARs, and GLP-1s in cirrhosis. I found this very stimulating and interesting. If you were not able to follow it live, we should have a recap on that, maybe separate occasion, because it was worth it.
Hoping to do so. In fact, unfortunately, I was hoping to view it, but I was not able to view it in real time, and there's no video follow-up, so I've missed that conference entirely.
So the big question is, why don't we, with NASH cirrhosis being the most severe complication of NASH and something that the regulators have accepted as an area of unmet need, why don't we move into that field? But then the question is, and in one of the talks, Scott Friedman used used the term of hot and cold fibrosis. So addressing the concept that you have cirrhotic livers where there's active inflammation. And if you're studying an MOA that will bring down inflammatory changes in the liver, that's probably very useful in hot fibrosis. However, there's a clear condition when the so-called cold fibrosis is just progressing, fibrosis progression or cirrhosis progression, because stellate cells are talking to each other, and it's not even necessary to have the outside insult anymore. And I think pathophysiological, that could be a different spectrum, in particular if you're trying to apply a drug and stop fibrosis progression or cirrhosis progression. And that concept, again, the ability to have these brilliant basic scientists, and Scott really, we had him on the podcast before, did such an amazing job in detailing some of those aspects, what he thinks where the field will go. I highlighted that. And I think from a drug development perspective, a clinical researcher, it's very intuitive that there are certain diseases that are more responsive to an anti-inflammatory, even the stage of cirrhosis, but then there's the point where probably the cirrhosis buildup is the most pressing problem. And I can't say that we have quite figured out yet which, if we take the biopsy, we stage it by fibrosis stage, the patient goes into the trial. If we see all components of the NAS, there's probably a spectrum within that. That's also related to differences in treatment response, obviously.
That would virtually scream for some kind of combination therapy, right? Because if you have to deal with inflammation and you have to deal with fibrosis at the same time, that might be 2 different agents or maybe 3 different agents.
You're right. And that's what the panel discussion was all about. So in the session I was involved, each speaker, there was Mazen Nourad and there was Naeem Al-Khouri, Manal Abdel Malik presented on PPARs. Each of us, I did the GLP-1 part, each of us detailed one MOA. And we kind of figured, in particular, if we have multiple drivers, the way forward is to combine this. Of course, that's the big question, which drugs would be working. And it could be depending on the baseline characteristics of the patient. Is he in a stage where he's actively fibrosing, passively fibrosing? Is it inflammation driving it? Do we need to control the metabolic derangement? So a lot of fun discussions and food for thought. That's why I like the special conference so much.
So it's fascinating. I hear you talk about actively fibrosing and passively fibrosing, and I start thinking about how do you get the right patients into trials? Because if you have a combination therapy that you think is appropriate for one of those situations more than the other, and you simply use typical random screens to get people in, you're going to start knocking your efficacy rates down, way down before you start, because the target isn't clearly defined enough. But how good are the tests to clearly define the target right now? And is the FDA willing to accept that? I don't know the answer to any of those questions. I just know how to ask.
And that kind of goes down the pipeline where we had a discussion with an FDA representative. The nature of these discussions is they can't commit to a definite answer, but of course they also opened up the view here a little bit. Again, surrogate endpoints around conditional approval, being biopsy at this time, and outcome trials, which the FDA would welcome, are of course difficult, also from a sponsor's perspective, but also patient and an investigator perspective. And it was a good discussion.
So for personal reasons, it's not worth going into. I think people who you two know and people who know the podcast know I've fundamentally been unable to travel since September. I was at Washington for one day for AASLD, but I didn't make it to Park City, although I wanted to. Didn't make it to California, although I wanted to, and I'm not going to make it to Liver Forum tomorrow, although I want to. Looking forward to seeing you guys again in Vienna, which will be my first trip, and will not be able to make it to Barcelona. Looking forward to joining you folks in Vienna at the end of June, which will be my first time out of the Pennsylvania area for, 8 or 9 months. So that's a meeting I'm sorry to have missed. It sounds like it was fantastic. With that, why don't we go to icebreakers? One good thing in the past week or one good thing in the next week? Jörn, why don't you make your icebreaker, not that it's a good thing, but talk a little bit about getting home.
Well, the good thing is I got home on Tuesday morning. I had a red-eye flight, got into Frankfurt at 5:30 a.m. They have a welcome lounge. It's actually a nice thing, so you could shower up, and then I hit straight to clinic. I actually had a long day and a presentation, which was held online at the Paris Hepatology Conference the same evening. So it was a long day. The good thing is I got home. I had planned differently, but it's a public disagreement on how much wage should be paid to the people working at the airport. They took the liberty to take the day off on Monday, so I got rewarded with a beautiful evening on Sunday in Los Angeles, which is not the best thing, but it was different than I planned, and I have to say I had pleasant company. We had a great dinner, and I had an early start then, traveling all of Monday, arriving early morning Tuesday. These things happen to Germany too. Yeah. There's some disagreements, and sometimes you have to go on strike. Everybody was saying, hey, this is not France, and I don't think it's to the same extent, but of course some union aspects here. It's the strength of the system that we have, participation of the employees in that context, and I think they've settled it out.
So that was your strike issue. So Louise, your strike issue is upcoming, maybe?
Yes. Well, no, it's going ahead. It'll just be an inconvenience, but no, I think we've got a lot of that at the moment. But Jörn was the only person I know who could make a strike sound so polite and welcoming. And you have our king in your country who was doing a little bit of the political manoeuvring, both laughing at each other and with each other. I thought that was quite a nice comment between Germany and the UK. His first official visit, because of course of the issues in France currently, a little bit more extreme than but we've had a number of strikes. But I suppose my icebreaker of the week is we've all been contacted, or we're trying to contact all of the nurses from my set, and the photo of our first photo of the combined set of 49 nurses back in the day, even my husband couldn't pick me out. I had dark hair and a lot of it, and call me Farrah Fawcett. I am naturally a brunette, and he couldn't. Well, he knows that anyway, but it is very funny. The comments going round the WhatsApp group of people as we track you down nearly 40 years later. So it's going to be fun. I'm not too sure I'm going to be in the country when we have the reunion just after Christmas, but it's been very entertaining to actually hook up with old friends that I'd lost contact with. It's going to be a nice thing going forward, even if I don't get to be at the reunion.
So you said it was 40 years ago. What's it like to go to nursing school when you're 6 years old?
Yes, I was a baby. More practical. More practical. That's all I can say. And I'm not against academic learning, but I do think we need to put a bit more practicality back in rather than tick lists. Those are just my views, but I know a lot of, Look, most people have actually probably left nursing. I'm one of the few that's still here.
And in your case, really only kind of, sort of, right? I mean, you're still in nursing, but not in the same sense that you were.
No.
All right. So I'll make my icebreaker, my positive thing, actually about the podcast. After chasing a bunch of attendance records for this podcast, we seem to have hit them all in 1 month, 1 quarter. We never quite got to 25,000 in a quarter before. The last 2 quarters, we were 24 something, but this one we're at about 28 something, maybe 29 when the quarter ends tomorrow. And we've never been over 10,000 in a month, and we are over 10,000 this month, despite the fact that we're posting our last episode on Friday morning, the 31st, instead of Wednesday evening, the 29th. Through the first 28 days, we were averaging 350 downloads a day, roughly. And the best previous month we'd ever had was about 325, and that was last month, and the best we had before that was 310. So obviously that's picking up. We had started picking up at an increasing rate followers on LinkedIn. I think 110 of those in the last quarter, which is the biggest quarter since the first quarter that we actually took followers through LinkedIn. And we've been growing our subscriber base, which you can only get into on the website by giving us email information, at about 10 a week or 15 a week, which was 3 to 4 a week before this quarter. So thanks everybody who's just joining us now for the first time, and thanks everybody who's been with us for a long time and told your friends and colleagues about us, which is why they're now joining us for the first time. And thank you to Louise and Jörn who make all this possible, and also to Jake and to Mike and to Eric and to Steve and everybody else in the background.
Congrats to the team. I think it's the people that are not on camera on tape here that really make magic out of this, and it's great to hear that season 4 really brings us to new records. You could have argued this is something you don't see post-COVID anymore, but I'm happy to hear that we're reaching out.
So, Jörn, my favorite conversation of the week was the one with you coming back from California and saying, you'd think as long as we've been doing this, people will get tired of it already, but they keep telling me they really like it. So let's keep going, okay? This second quarter, consistent with everything else, the pace of change increases, and the second quarter has just a ton of stuff in it. And I think where I'd like to start is I'd like to ask each of the three of us to pick the one thing that's going to happen in the second quarter that we think is likely to be the most momentous or most compelling. Brave one, go first.
I'll jump in because we've discussed it on the podcast a fair bit. The anticipated approval by the National Institute of Healthcare Excellence in the UK for FibroScan to be in the community and primary care setting for liver pathways. And I think we're waiting on the publication of that because it's been through a lengthy documentation. But one of the reasons that NICE is so important is there are a lot of countries that don't do the cost-effective analysis or these reviews in such an intense way and look to the UK system and NICE's approval before they will change their healthcare or look at these areas. So it's a gear stick for me for what could potentially happen. This will be followed. It has already been announced that the UK government is going to invest £2.3 billion over 2 years to put more liver non-invasive diagnostics, aka FibroScan, into our diagnostic hubs. So there is a genuine commitment that I see at a government level. And I think I said to you earlier, just personally, that Jeff Lazarus wrote a lovely report and showed a great poster at EASL a couple of years ago that was on who was the most prepared to be able to do an AFLD policy and implement that strategy. And the UK came top, although he was very keen to also say that everybody failed. The UK just failed less than anybody else. So
yes, when you said most prepared, I was thinking least unprepared is more like what he said. But yeah, that's right.
Absolutely. But I think there's a momentum that we haven't had before. It's whether whether or not we grab the momentum in the right ways, because you can get momentum in any disease field, but it can get washed away because other people just don't bring it on. So I think there is excitement, but there's trepidation that we don't do it in the right way. We make it labour intensive or too cumbersome to be able to get out there. But just picking up on Jörn's point from the conference, for me, that rang alarm bells. If we have two types of cirrhosis and we can't differentiate these two types on a biopsy, therefore the biggest need we have is stopping people getting to cirrhosis. And therefore that early detection gives us those opportunities to stop this hot and cold type of cirrhosis. So it becomes more important for early diagnosis. That for me is going to be important to see over the next, not just 3 months, but the next couple of years as this rolls out, and the domino effect that it could have. So
this will be our episode on April 24th, which is not the episode right after Louise comes back. That'll be our anniversary episode, which I'll talk about at some point today. But the week after that, we'll talk about those two stories, the NICE paper and the NHS England funding commitment, which after all these years firmly locked into my head. How do you type a pound sign on an Apple US English keyboard, which I'd never known how to do before without odd codes, but it turns out they made it simpler. You just go option 3 and there you are. So Louise, you've only been working on this forever. So it'll be exciting to see some of that stuff come to fruition.
This is great news from my side. Also, Louise, I think it's a strong signal forward. I mean, if a system that's based as much and strongly on referral and cost effectiveness as the UK implements, as we're going to get numbers for your system, for your healthcare system on the cost effectivity and the referrals. And I know this is going to be accompanied by some analyses that will show us how many detections we're going to make in which context. So I think this is very important and an interesting concept moving forward. I can tell you, I'm looking forward to our discussion on this. I'm involved in at least 2 or 3, let's say, research applications and some current research that looks at screening of the entire population for liver disease. And one of the big challenges is, what approach do we use? How much money do we spend? What is the accuracy of the tests? And I do see that the UK has found a good approach. I'm convinced that the approach will, identify advanced cases that haven't been identified, so we'll be preventing end stage, and the technology behind it is useful.
Jörn, I couldn't agree with you more. I also think that the fact that it's the UK doing this first speaks not only to Jeff's comment about who was least unprepared a couple of years ago, but also to the differences in terms of how the health systems look at investment in care. You know, in the US, we have tons of money invested in electronic medical records because Obama made that a pivotal element in the Affordable Care Act. And as a result, it's somewhat easier for us to capture real-time patient data on basic things like complete blood panels than it is in some other parts of the world. The idea that so much of our insurance is private and funded annually and that we have high patient turnover means that it's difficult to envision who would be willing to make the kind of investment that the British system, which has more centralized cost and is based more on qualities and cost effectiveness, is making. So, you can debate which systems are better at the others for doing what, but on this one, living on this side of the pond, I'm clearly jealous. I think that the government systems and the folks who take a look at efficiency in a broader context are going to do better on this, better on preventive.
We batter the NHS and we batter a lot of the health systems by not being good enough. For me, and not to give too much of the discussion for the episode we're going to cover it on, but it's about the investment in keeping people healthy. The only way we are going to save healthcare in any system is to stop getting sick where we can prevent it, because we don't have enough staff, we don't have enough opportunities to train. So, and I don't think it's born out of that. I think it is genuinely born out of the fact that liver disease has been one of the most under-recognised serious health conditions that is so intrinsic into all of the major ones that we are now saying, looking at the elephant in the room, we're just going to be in a position, I hope, that we can find the elephant in the room a lot easier, quicker, and stop patients waiting months and months on end for a discussion about it. So for me, obviously, I've talked about it for a long time, but this is the hard work of the British Liver Trust, the MPs, all of the experts that sit on these panels, and patients. And they're getting a result, and that, for me, is vital.
Pardon the small digression, and then we'll go to Jörn. But when you talk about the elephant in the room, I've taken to using 2 metaphors to describe NASH and liver disease and its place in the world. One of which is the parable of the blind people touching the elephant, where depending upon whether you're touching a tusk or the trunk or one of the legs or where you are, it's a completely different animal. And I think when people look at liver disease, on the one hand, we have Stephen Harrison's metaphor about the canary in the coal mine, which is very small and very finite. And then we have 6 blind people touching an elephant. There is a Japanese movie, I think in the 40s or 50s, called Rashomon, which is a classic presentation on multiple people describing the same event in radically different ways. You'll hear this phrase from me more as time goes on. I've taken into calling the phenomenon of how we look at the liver the NASHimon, because it rhymes, and therefore it's not alliterative. The litter is the first letter. It rhymes, so it's visual. And NASH is very much that. People look at it, and depending upon where you are, you see a very different story. I agree with you. Where you're looking at it right now, at the front end, when you can still prevent pretty quickly if you want to take action, is the place we all should be looking more. So welcome to the NASHimon. Jörn, pick an event for the first quarter that you want to talk about.
The first quarter runs till end of June, right? My scientific highlight is going to be ILC in Vienna, because the amount of data we're going to be seeing there will be incremental. There's going to be phase 3 data in my expectations going to be presented outside of press releases for the first time. There will be a wealth of biomarker data, even some predicting outcomes, which is the hot field at this point. We need biomarkers that we can use to risk stratify patients. There might be even some data as a preview to predict drug treatment response from some phase 2 trials potentially. And I think the excitement of many of the questions that we're asking, wondering for, being answered in high quality data sets is one of my highlights. And of course, meeting people, potentially getting back together with you, Roger. Let's try to not record in a bathroom this time. Seeing Louise crouching in the shower again. Clearly, those are highlights.
We'll avoid that. I think we may just go back to doing what we...
We all had clothes on.
Yes, we did.
We just have to stress this.
Well, I've landed on having people record out of their hotel rooms as being the best way to go. Although there's a chance that we'll be doing some live real-time interviewing in Vienna as well. And I agree, Jörn, I'm excited to see people that I've gotten accustomed to seeing in person that I've now not seen for 8 or 9 months. And I think the data at that meeting will be fantastic. It also should be noted, it's the weekend right after which goes to my event, the PDUFA date for the review of obeticholic acid. So it's conceivable that we will have a response from the FDA by the time we get there if they stay on PDUFA schedule. And many are hopeful that that will be an approval. And if, in fact, that were the case, it would make Vienna a whole different meeting.
I agree. It would move the momentum in the field dramatically. Now, my question is how much of the detailed discussions are going to be able to go outside of that closed room? Of course, we're going to get the final reports, but the interesting aspects will be, which way did the discussion go? Which aspects were assessed differently this time? And the more data that be available from that discussion, I think it's going to inform the field and going to be very helpful for future developments.
Completely agree. And one of the things we're going to try to do in the second quarter, if I can figure out how to do it, is cover the ad board meeting, which is on May 19th. So that should, it's not a perfect predictor of what's going to happen in June, but it will be helpful because we can compare it to what happened 3 years ago. And I'm hoping that we can figure out how to get enough insight or information out of that meeting to make a compelling episode for the middle part of May. And frankly, I think obeticholic acid is my story of the second quarter. That, and I'm assuming, which is foolish, that resmetirom should be filing right around them, and hoping that they can file in the second quarter because that would get them to their PDUFA date before the end of the year. And we could actually exit 2023 really in a good place if that were to happen. I have no information about when that'll take place, but it's a possibility.
What does PDUFA stand for?
It refers to when you file, the FDA gives you a deadline by which it has to either come to a decision or defer a decision. The PDUFA date is that date. And if you're on accelerated approval, that's a 6-month timeline. If you're not, it's a 1-year timeline. Early NASH drugs are all on accelerated approval.
So it's actually the Prescription Drug User Free Act, PDUFA.
Thank you.
But you know more about it than I, having operated in that system.
Right. It's the enabling legislation. And this was originally the legislation when they increased budget for FDA by allowing manufacturers to incur some of the cost of getting to the date in exchange for commitment. Before that, we were really laggards on drug approvals because the thing stacked up at FDA forever. So it made FDA more efficient. It made the U.S. frequently the fastest to approve drugs in the world, which it had not been before that. And that is the act.
Expediting drug review and approval, which is a great thing, again, for patients and, of course, the way the drug development works. Well, the other thing that I'd like to highlight is, of course, Intercept has not a great presence in Europe anymore and has passed on those drug rights to a different company. And we're trailing a little bit here, which is the sad news for patients in Europe. Moving forward, I'm hopeful that we'll get similar responses in Europe, and this will also be beneficial then for us.
I think that's right. And frankly, if the U.S. approves, I think that will be a marker to what's going to happen everywhere else. So hopefully as soon as possible, but approval would be huge. Approval would cause dramatic increases, I think, in investment by big drug companies and private investors and everybody else, and would just really be a fantastic thing. We're also, I think, going to be, as you point out, Jörn, a lot of phase 3 published outside of press releases in Vienna, but we're going to be seeing more press releases, right? You and I were talking about this last week offline, the phase 2B Bio89 results, which is second FGF21, in some ways very similar to efruxifermin, to the Kero results, in some ways a little bit different, but a lot of the drug trials that were delayed because of the pandemic are now starting to come up the pike. And we should be starting to see more data more frequently because of the combination of things now coming to fruition and investment becoming more common. And
I agree. And we could probably talk about that for another full episode. The results of pegozafermin being presented in press release and some of the notable statistics around that drug, which were also discussed during the ASLD meeting, at least off the stage, and a low placebo response rates for something that we haven't seen in the field. Fibrosis regression and placebo by 7%, NASH resolution at 2%. The metrics behind that and how can that be is something that is not by chance, but by defining and refining the way the results are reported today. So we've made leaps, I would say, in the field in reporting outcomes.
We have an awful lot to do in the second quarter, Jörn, and I agree with you. I would love to get an episode in that talks about that. And more, Stephen and Naeem and Mazen and Alina Allen published a paper recently on NASH drug trial challenges. I'm hoping that we can get 1, 2, maybe 3 of those folks to come join us for a week in May or in June, since April's already spoken for, and talk about that paper, because clearly all the discussion over the last year and a half or two about how to make trials work better is coming to ferment, and we're seeing it in things like pegozafermin placebo response rates. So it will be exciting to talk about their paper and about all the places that we're making progress and where we think we're going to make more.
Yeah, and let me just add, you were mentioning a paper. So this is a review published in Nature Medicine, which is one of the highest ranked reviews journals we're looking at. And clearly them covering this shows the momentum and the way forward and the wealth of data we've generated. So congratulations to those 4 authors. Again, a great piece and well-respected colleagues.
Alina put a comment on Twitter that I think speaks to the experience we all have in this podcast as well, which is it's so much easier when you're working with your friends, with one of her comments on the paper. Those are 3 things. What else do we want to cover on today that's going to happen in the second quarter?
I'll cover something that I don't think, sadly, will be covered. It'll be the allied health education so that we get to roll these medications out. If we're as close as we think we are, we should have already started, and we haven't. I haven't seen much. There's a fair amount in the physician's level because we discuss it here regularly. There's a fair amount in the patient advocacy arena to make patients aware that this is coming. These people are going to front up to nurses, whether it's in cardiology, endocrinology, and hepatology. And remember, there is no skill set for NASH and NAFLD in hepatology. I've said it before, we only get to see in a hepatology specialist unit, as I'm sure Jörn will say, we only get to see the sick liver patients. We don't need to see them then. So our skill set is liver disease. It is not talking to patients about NAFLD and NASH. It is not health education on that level because we don't see them. And yet we've got very little of any education going in to now give the skill set to roll out all of this information, because it is fascinating information. It is a real area that nurses can change people's lives on 1 or 2 interactions before they get to a physician or after they've got to a physician. So that teamwork we're not really working on, and it's going to be absolutely vital. So that's one thing I haven't really seen, and I know I talk about it and I a lot in the fact, but I think it's absolutely vital to how we're going to get these medications out or get people through pathways to prove that they're entitled to these medications. This will not be everybody gets access to resmetirom, obeticholic acid without certainly a few hurdles being put in the way. And who's going to monitor those hurdles? There's a lot of pathway work and structure to go in, and yet I haven't heard a lot of that discussion. So I think that's what's not happening in the next 3 months. But I'd like to see us start to get it within the next 6 to 9 months, because we're going to need it.
Couldn't agree more. And Louise, last year in Barcelona, we had you come on stage and we had a discussion around that and agreed that allied health profession is the support. And actually the primary care physician from Belgium said that. And I remember well in his talk, he can't see all these patients. It's the patients that are with his nurses that are in the diabetes control programs. We have a disease management program in Germany. They show up for the prescription. They show up for their, body weight check and urine dipstick and maybe get a quick reminder on nutritional. And those are the contexts in the healthcare system. Imagine we have a drug and we don't identify the patients. This is like missing out on providing disparate healthcare. And I agree, it's the physicians are going to be overwhelmed by selecting those patients. So we need that help. And that comes up every once in a while. Now, allied health professionals are not not used to the same extent in every healthcare system. And for me, that's a clear disadvantage in the German system. But I do see how the UK could benefit. And unfortunately, we don't have it on the program this year in Barcelona with the implications, innovations in NAFLD care. But it's something we have to revisit. And I'm with you. This has to be revisited and see how we get the patients that are eligible to actually access the drug once it's there.
Excellent point. Let me share a number that we talk about a lot on Rising Tide, but not a lot on this podcast because that's for frontline treaters. In the U.S. right now, the government estimates through the Health Resources Administration that there are probably about 250,000 frontline prescribers for metabolic diseases, including primary care, internists of primary care, endocrinologists, and physician assistants and nurse practitioners. And of those, I think the number is that about 40% of those are non-physicians or allied providers. Between the nurse practitioners and the PAs, I think you get up to about 100,000. And then you put 150,000 on top of that. And then for older populations, you put some gerontologists on top of that, or geriatricians really on top of that. So the good news there, Louise, I think from your perspective, or from the perspective you're taking in this conversation, all of our perspectives, is that approval in the U.S. will lead to rather aggressive allied health education over here by many of the same companies that will be bringing product to market in the rest of the world. So now, admittedly, that's company-driven education, not as unbiased, if you will, as education that you would get if it came out of governments or universities. But it will bespeak a significant increase in investment and understanding the role that the allied health professionals play in systems. So I think that's a good thing. One of the things we do better in the U.S., and the things we do better, things we do worse. I think that'll help. And I agree with that. I think that will be pivotally important. Jörn, you have a second you want to mention?
I would hope that some of the phase 3 studies will complete enrollment. I would hope that recruitment of some of the phase 3 trials are picking up. So that's maybe something that's not as much in the public domain. I'm not meaning secretly, but it's not so as much in the focus. But the ongoing phase 3 programs, and we have 4 active ones, not all are fully recruited yet. And that's an important task for all these investigators out there.
So I think it's not in the public domain, but you do see it. I think I saw, if I recall correctly, the Galectin announced that they had finished recruiting for their enrollment for their phase 2/3 adaptive cirrhosis trial. Recruitment is a predictor to where we're going to have data, right? So as we see things enroll more aggressively, start to finish enrollment, change trial designs, I think all these are promising things. I agree. I'm excited about International NASH Day. I'm excited because GLI's footprint continues to broaden. I know Louise has a specific interest in Australia that maybe you'll say a couple of words about in a minute. And we're going to actually do an episode on that in 2 weeks, where we're going to come on and talk about why is it that GLI thinks that International NASH Day this year is so much more vital and important than it's been in previous years, and some of the activities that they'll have as part of this year. Because A, as drugs come to market, and B, the rate of growth of disease is not slowing down any, right? The latest numbers I've seen are now estimating maybe 35% of adults worldwide, whereas the number that we saw used recently by ICER in the U.S. was 25%, which is a number that's only 3-4 years old. So the pace of disease continues to increase. We will have therapies available. And I know that GLI is anticipating doing things that are bolder and more aggressive in pursuit of A, global reach, and B, an appreciation of the breadth of the disease. And I don't know a lot about what they're going to do. We'll learn more in a couple of weeks, but I will be intrigued to see because they usually come up with cool things. I'm also hoping they'll have us back on to do their wrap-up session again. That's a shameless public plug to Jeff and Donna. But so I'll be excited to see how that goes.
Every year, they nail it and bring something new to the field. And I think it just gets bigger and bigger. And that's a testament to how they're globally engaged. And we're getting Australia were there last year. I think if it was the hepatitis unit in Brisbane were there, I'm not too sure. I'm not involved in the Australian side at the moment from getting the Liver Association or that on board. But I'm sure we will get Australia to the table at some stage. But they've certainly engaged a lot more in liver, I think. And that interview with Tony Rahman says we've still got a long way to go. But we'll keep badgering on.
And besides which, Louise, now the pandemic is over, is going to start spending a lot more of your time in Australia, right?
Yeah, about 50-50.
That should be a rate increaser, just your mere presence and energy and passion.
If not, it's a warning. Get out of Dodge unless you want your liver checked. I'm saving their livers one liver at a time around the world, but I don't mind being vocal because it helps. We get so much good and positive feedback where we take people off these timelines or get them into care quicker, and it's about getting to the right person quicker. It doesn't matter what country, we've all got a liver.
Very well said, Louise. And the way we try this here, again, we don't have the care pathways that put this in place, but I try this within research projects, and we're going out into the communities and was actually thinking about, evolving the Turkish community in Germany a little more. I said that in one of the very first podcasts, and Donna has actually sent me a Turkish patient information, which I still have. And now a Turkish student approached me recently, and we were thinking of starting this project in the Turkish population because there's a lot of barriers in subpopulations that are still at metabolic risk. There are part of the society has been here in second or third generation. Still, I think the knowledge on some of these diseases is maybe not as high, or from a different perspective. Coming from Turkey, there's a lot of HBV, and people are maybe associating liver disease with different aspects. In Germany, they would always associate it with alcoholism, and potentially German and Turkish patients are very much different here. All these things we don't know. So why am I saying that? I think that going to the communities, going where the liver is, as you said, or let's say the patient with a liver, checking them and inquiring them about their ideas, their barriers to access care is so important. And this is a project, if it works well, I'm for sure going to report on it in the podcast again in the future.
Oh, I might have to come and have a look.
Yeah, please.
I think what people do engage with from the communities, if they think about it as hepatitis B, they still have bad diets. What we're trying to do is stop the second disease compounding the first. And I think they buy into that whole, you mean I could be giving myself, because we know hepatitis B increases in speed. We know any double liver problem is often a doubling in speed to cirrhosis. By finding and scanning and making sure that if you've got hepatitis B, that we maximise your liver health, or an autoimmune condition, if we maximise the liver health elsewhere, this is the importance. Jörn's absolutely right. Getting into these communities, because there's barriers within the communities, sexuality, every age, all sorts of things within their own communities, which you see in the UK a lot, because and Germany has a very diverse population the same way as we do, and you really do have to get into those communities, but be welcomed in, or teach the community to do it themselves.
And I think the global phenomenon, Louise, is true everywhere, is that increasingly the communities maintain their language and habits. Okay. So just in the last 20 years that I've lived where I live now, which is a suburb of Philadelphia, 20 years ago, if you were walking out on the street in New Hope, my town, which is a bit of a local tourist town, on a Saturday, you would hear English, you would hear a little bit of Spanish. Now you hear a lot of Russian, you hear some Italian, you hear a few other languages. People just keep their languages with them. And when you talk, Jörn, about third generation Turkish people living in Germany who are still more comfortable in Turkish than they are in German, that's I think, becoming a more common phenomenon in many, many different places.
I can't say that, and maybe also I'm not having a representative impression here, but for sure you maintain your roots, and it's a culture. And me moving to a different country, I would maintain a lot of my roots and culture. I mean, that's what made America great, the melting pot. That's what I learned about in school, and it's the culture that the people relate to, and that, as Louise rightfully said, means habits. And in a different environment, these habits can be a different health threat, and the additive effects of Hep B and overnutrition in a German society will always be alcohol consumption to a certain degree. And I used to say to my patients, it's a self-made decision about quality of life, consuming a glass of wine versus health and liver disease. We see more and more evidence I should be stricter, recommending absolute abstinence. And I can't, even as a physician of liver disease, I'm not so strict with all my patients. Sometimes I'm afraid I'll lose them because they're just going to stop listening to me.
A friend of mine who's a sleep specialist was talking about dealing with people with weight and apnea, and made the comment that you can only take people where they're willing to go as fast as they're willing to get there. And that shapes a lot of his decisions. So I was listening to what you were saying, and what was in the back of my mind, Jörn, was the increase in alcohol consumption virtually all over the world during the pandemic. So we're now dealing with a higher alcohol baseline than we were. And if by advocating abstinence, you can get people maybe not to abstain, but to dial themselves back further than they would otherwise, that's a good thing, yeah? And if you get them to abstain, then of course you get full hero points. But I think it's the challenge.
I can't do everything at once, right? So you should join me in clinic one day. You'll see how that goes. And Louise knows all these discussions. Well, and I would need a nurse like Louise to enforce what I've said.
At one point in time, you made a comment to Mazen and me that we should stop in Stuttgart and go see your clinic on the way to Vienna. And if I can make my schedule work, I intend to take you up on that. No commitment yet, but I'm hoping to do that.
But you use the lie detector that is the FibroScan. Yes, doctor, I've changed my diet. Well, let's see what the scan said. Oh, on second thought, I didn't really do it as much as I said I did. It is fantastic but they also compete. My scan should be better this time. So this is what we don't measure in research trials. This is what I talk about, but we don't measure that impact. There was a poster out last easel about one scan. 5 years later, these patients had still changed their lifestyle. It wasn't perfect, but they had still gone on to make a difference. But that was from one scan in a drug and alcohol setting. They weren't able to do.
Yeah, that was from the Odense group.
Yes. So, but this is the fun. You've got a lie detector now, and it is hysterical, the engagement that you get with it. It's one of the funniest things you'll ever do, because 99.9% of the time, the scan will tell you whether or not that person has changed their lifestyle for the good or the bad. And if you want to ever see what a fast food diet does to your liver in a month, then it is not nice.
I'm visualizing a promotional campaign for EchoSense, or maybe Sonic Insights or Escopics, both of whom are now starting to become more aggressive in promotion, that is basically someone in a black coat and a black hat pointing at you and going, "You lie," and I've got the proof right here.
Absolutely. I never say that. I said, could you rephrase that? On second thoughts, I didn't.
So we're kind of rounding towards the bottom of the hour. I would be remiss if I didn't tell everyone who listens to this podcast that you really would like to see if you can join our audience on April 17th, or if not, catch our podcast on April 19th, because that will be our 3rd birthday celebration. We already have 2 audience participation games as part of the event. We'll be rolling those out next week, where people can win prizes. One of those is I will announce this one. We talked about this once on the podcast. I think the Magic Mike Milson drinking game, our audio engineer who has listened to every episode that we've put out since July of 2020 and has phrases that he associates with each of the regular and semi-regular surfers. We will have his drinking game, which is the one phrase that you associate most readily with Louise, with Jörn, and with me. You'll be able to submit all 3. And because it's a drinking game in fatty liver disease, the winner will get a bag or 2 of my very favorite coffee, which is a coffee grown in the U.S. It's a medium roast with lion's mane and chaga mushrooms for added supplement. And then we have a couple of other games that will be coming as well, and a couple of other prizes. And we will have a couple of interviews. Hopefully some of our past regulars will come on for a few minutes and say hi and let us know what they've been up to, and maybe some of our sponsors as well. So we'll see. It should be a fun episode all along. There will be live audience. If you are a subscriber, or if you want to go through the light gate on the surfingthenash.com website and become a subscriber, you'll get an invitation for how to get there. And it should be a fun day. I'm mindful of the idea that people told us we'd have to stop after 15 episodes because we'd run out of things to talk about. And then you get an episode like this where we didn't set up anything to talk about, and we could, as you point out, go for 4 hours, just the 3 of us.
Speaks to the gang. Yeah, I was trying to think what my phrase is, and I can't figure it out. So I'll be happy to learn.
I'm going to not say anything. That's not my phrase.
Those are already in the envelope. I know what the winners are. I'm not a participant in this contest. And the bonus round will be probably a Stephen Harrisonism, or 3 Stephen Harrisonisms of choice, because of those we've got. I mean, I said canary in the coal mine half an hour ago just to prove that we got there at least once today. All right. So with that, why don't we, I don't really know how to wrap this up. Here's my wrap up. No one knows this is coming, including me. So we've talked about the second quarter. What do you think is the one most momentous thing you see happening in the second half of the year? And I understand this is way in the future. No one's prepared. So these are all going to be wild shot guesses, but go for it.
That we get another country that's going to take on liver disease and start to roll out a little bit more high level involvement in looking for liver health. And then we'll find the disease, but we'll find the endocrine and cardiac health as well. I'm hoping that we'll be the first, but I'm hoping somebody else will start to engage in that as well. And we can help.
So as an academic clinician, my highlight would be to see more research grants being awarded in the arena of liver screening. We urgently need a clinical trial showing superiority of screening versus no screening in the general population and specialty populations to show a benefit, which will allow us to actually talk with the regulators. And there are some great initiatives on the way, nothing that could be put up into the public yet, but I'm very optimistic that we'll see great research consortia be forming to answer that question finally. That would be an absolute highlight for me.
That would be fantastic. I think the one I'm going to pick, and I'm completely making this up, I have no data at all to support me, is I grow increasingly schizophrenic about biopsy. The extraordinary value that some of the AI-assisted analyses can do in terms of things like zone of liver and disease metabolism on the one hand, and on the other hand, the ability of the consortia to prove that we don't need biopsy to figure out who's doing well, and to be able, Jörn mentioned early that we're going to need to start to figure out which drugs work faster than the AT&T 18 months that they're given in a clinical trial to show one level reduction in fibrosis. Because in the States, people are unlikely to pay for that. So I'm hopeful that we make progress on both those fronts. Better understanding of underlying disease based on better use of AI-related biopsy tools. And then on the other hand, progress in terms of understanding how to evaluate whether drugs are working faster and whether patients are succeeding faster so that we can make more informed, less economically driven decisions about which patient gets which drug at which point in time. I'm not sure that's all going to happen in the second half, but I'm confident we're going to make progress on it because I know of enough things that are going on. So with that, Jörn, thank you for figuring out how to get an hour into your week to do this, given what your week has been. And I'll see you, you and I will probably be online together over the next day and a half, and I'll see you on Monday. Louise, have a wonderful time in Vancouver.
Thank you.
Rumor has it we might invite you in to do a commentary interview on the April 10th, the International NASH Day episode, and then you'll be back with us for the celebration.
Before or after ski, Louise?
It could, time zone, it'll be before. Could be lunchtime.
It doesn't have to be. If it's just me, then it can be your cocktail hour and my pre-dinner glass of wine.
Yes.
Okay, with that, let's all say goodbye, and we'll be back with the business report in just a minute, and everybody have a great weekend. Okay.
Yeah,
Bye-bye.
Thank you. Bye-bye.
And now for the Season 4, Episode 14 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. As of Wednesday afternoon, this appears to have been a light news week in Ukraine. For Ukraine, though, silence and apathy are the enemy, as much as Russia. So we will remember every week, even if there's nothing to report. Slava Ukraini, Heroyam Slava.
Our third birthday party is starting to take shape.
We will record our third birthday episode on April 17th and post it 2 days later, the 19th. As I mentioned last week, listeners, subscribers should keep an eye out maybe next week for an invitation to attend live. I've started reaching out to past sponsors and corporate allies, and we're planning games and contests at the start of the event. Keep paying attention. We're going to have prizes to give out. It should be pretty cool.
We have some new download records.
We've been maintaining a 350 per day download average throughout the month, well, at least through March 28th. Without an episode to record on March 29th, the next day or two might be lighter. Nonetheless, we've already broken our 1 month record in March, our 1 quarter record this quarter, and are challenging 2 key download barriers. This is our first quarter over 25,000. As I mentioned last week, we've already surpassed 28,000, might get to 29,000. And as I write this on March 29th, we stand over 9,900 downloads for the month, and we'll probably break through 10,000 for the first time. Guess we're going to need some new goals, hey?
Next month's episodes really look great.
I'm really excited about April. Next week, we cover the Liver Forum 14 meeting taking place in Washington, D.C. this Friday and Saturday. The following week is our pre-episode for International NASH Day, focusing on why it is so important this year for everyone around the world to play a role. The week after that is the third birthday celebration I just mentioned. And we round out the month by looking at 2 recent UK decisions on liver scans. The nice final decision on FibroScan and primary care, which we hope will be out by then, so recent is in the future. And a report that NHS England is looking to spend £2.3 billion to open 100 FibroScan centers all over England by 2025. After that, May also looks like a pretty good month, with meeting previews, meeting events, and at least 1 major drug update episode. So to me, we have 2 fantastic months ahead. Get ready to listen to a lot of good stuff.
As we record our voiceovers, this week's Vault episode is a mystery to us all.
Because we're not recording the live episode until tomorrow, I'm writing and recording this back end before I know exactly what we're going to say in the episode. As a result, I'm not certain what the Vault episode will be. I usually don't decide until I've heard the recording. So you're just going to have to listen and keep your eyes peeled over the weekend to find out what the Vault is. And with that, I'm off for another week. Thanks to Jake, Magic Mike, Steve, and Eric for helping to get this episode out the door on this crazy late schedule. As I mentioned a moment ago, next week we're covering Liver Forum 14. So until then, make sure to let us know how you feel about Rising Tide and about NASH Tsunami. Don't forget to send reviews. Stay safe. Surf on. We'll see you next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.